Well, good afternoon, everyone. I am Erica Trappel. I'm the director of the Prevention Research Center for Healthy Neighborhoods, and I'm excited to welcome you all to our June research seminar, which we are co-hosting with the Community and Collaboration Core of the Clinical and Translational Science Collaborative here at Case Western Reserve University. Today's talk will be integrating data evaluating asthma risk in childhood to plan community-engaged interventions. So before we get started, I just want to provide a few reminders. We welcome you and encourage you to connect with us. You can see our website at www.prchn.org, and our socials are on the right-hand side. We do record all of our seminars and we post them on our YouTube channel, which you can access through our website. We want to thank all of you who've attended with us this past year as we've continued to be virtual. We've had a phenomenal series this past academic year. And if you've missed any of our previous presentations, we encourage you to visit our seminar page, prchn.org/seminar, to see our previous presentations. And one of the things that we still continue to miss being in this virtual environment is the ability to see each other and get to know who's in our audience and have those little side conversations. So we encourage you all to use the chat box to add your name and organization to introduce yourself to others who are on our call today. And then use that chat feature to type in your questions as we move through the presentation this afternoon. Okay. At this time, I'm going to hand the introduction over to my colleague, Dr. Elaine Borowski, who leads the Community and Collaboration Core, and who will do our formal introduction. Elaine?
Okay, thanks, Erica. So good afternoon, everybody. As Erica mentioned, this seminar today is co-sponsored by our Clinical and Community and Collaboration Core, which is a part of the Clinical and Translational Science Collaborative here at Case Western Reserve. And so the goal of our Community and Collaboration Core is to really foster effective investigative teams that are enriched by a diversity of stakeholders from the community to address together the health and the healthcare priorities of our local community. And so one way we do this is to provide support, financial support to interdisciplinary collaboratives that both engage and serve the health needs of our local community. And the project you're going to hear today is one of these wonderful collaborations that are between clinicians, data scientists, and evaluators at the Rainbow Center for Child Health and Policy, and also with our wonderful Poverty Center at the Mandel Center, and many of the community partners that provide both data on childhood asthma and use these data to develop effective community-based interventions. And so, further ado, I'm going to introduce our wonderful speakers. First, I'd like to introduce Dr. Sarah Ronis, who's the director of the University Hospital's Rainbow Center for Child Health and Policy. She's also an assistant professor of pediatrics at Case Western in the School of Medicine. Her research expertise is in the embedded evaluation of interventions that are based in patient-centered medical home to improve the quality of life and clinical outcomes for this population, emphasizing the contributions of both qualitative and mixed methods approaches to leverage the perspectives of multiple stakeholders, like I mentioned, in these kinds of research efforts. She serves on national forums addressing quality of care and health outcomes for children with special healthcare needs, including being a co-investigator with a HRSA-funded maternal child health measurement research network, and as domain lead for advocacy with the HRSA Emergency Medical Services for Children Improvement and Innovation Center, where she facilitates the EMSC Family Advisory Network. She obtained her medical degree from Case, her master's degree and her MPH from the University of Rochester, and believe it or not, currently is a PhD candidate in clinical and translational science here at Case Western. Our second speaker is Marie Masotya, who is a senior research coordinator at the same research center at UH for Child Health and Policy, where she manages research, quality, and community-based projects. Her current work involves design and implementation, again, of this mixed method evaluation of programs and services that are offered by the center. She represents UH Rainbow on several multi-sectoral community partnerships that are focused on child health and health equity. She also has her MPH from Cleveland State, and her research interests focus on child and family health and well-being, community-based participatory methods, and health equity. And finally, and not least, Dr. Megan Atwell is the Associate Director of the Center on Poverty and Community Development at Case Western Reserve. She conducts research and program evaluation aimed at alleviating the effects of poverty on Cuyahoga County children, youth, and families. Megan also provides strategic direction for the Child Household Integrated Data Child System, which is a comprehensive county-level integrated data system on children that were born from 1989 to the present. Previously, Megan lived in DC and worked for the Pew Charitable Trust and the Urban Institute. She received her PhD in public policy and public administration from George Washington University with a focus on urban and social policy. I'd like to welcome each of you. Thank you for coming today, and we're all very excited to hear your talk. And I'll turn it over to Dr. Ronis then.
Well, thank you very much for that introduction, for the invitation, for the support, for the work that got us here today. On behalf of myself and my co-presenters, we are delighted to be here to talk with you and hopefully spark some conversation. Dr. Borowski mentioned that I have some funding from HRSA. This is my mandatory disclosure that nothing I talk about today has anything to do with EIIC, HRSA, or EMSC, and nothing has been approved or endorsed by the federal government. And I wanted to actually start by acknowledging really the broader team that has initiated this work, shepherded this work to this point. We're going to talk about the origins of this project, which actually date back, I'm looking at Marie to correct me, to 2014, 2015, under the leadership of Dr. Andrew Hertz in partnership with Dr. Claudia Colton and our former director at CCHP, Larry Kleinman. I also want to acknowledge Ann Nevar, who was program manager at CCHP at the origins of this project. She's now been working with Ohio Medicaid through the cardio program in more recent years. Dr. Christy Ross, Division Chief of Pediatric Pulmonology at UH Rainbow, who has been a core member of the team from the inception, remains so, but was not available to join us today. So I'm speaking partly on Dr. Ross's behalf. As well as direct acknowledgement and gratitude to Alina Sorensen and Stephen Say from the Center on Poverty and Community Development, who were really instrumental in actually conducting the work we're going to talk about, as well as the other members of CCHP and the Center on Urban Poverty. Our objectives for this hour are threefold. I want to talk a little bit about social risk factors for childhood asthma disparities that underpin the motivation for this project. We're going to talk about potential benefits of engaging non-clinical data partners in health-based research. Personally, I'm coming at this from the healthcare system lens, but I think Megan and Marie are going to have some interesting perspectives to share as well. And then use it as sort of a jumping off point to talk through success strategies for similar future endeavors and where this work might go in the future. So this team came together really motivated by the high prevalence of childhood asthma, which is among the most common chronic conditions of childhood. Nationally, about 8% of children and youth under the age of 18 have asthma, which translates into a population prevalence of about 6 million children nationally. Of those 6 million children in any given year, or more than half will have at least one attack. So an exacerbation that warrants some degree of intervention. The vast majority of those who require intervention will do so in their home, school, primary care office, or urgent care, but a not insubstantial proportion, or 700,000 children, there will be 700,000 of those attacks will lead to an emergency department visit. So requiring a higher level of care and intervention. Of those 700,000 emergency department visits, nearly 140,000 will result in an inpatient hospitalization or intensive care stay. And of those, there will be about 200 deaths per year. So on the grand scheme of things, kids are generally healthy, stay healthy. This is a condition with substantial, not only morbidity, but mortality. And in Northeast Ohio, we are in the Asthma Belt with more than twice national prevalence of asthma and substantial persistent disparities by race. So this is national level data from about 4-ish years ago. And what I really wanted to draw your attention to here is that compared to non-Hispanic white children, Black children nationally have about twice the rates of asthma. Same thing in Ohio, that increases, and as many as up to a quarter of children, Black children in Cleveland, have a diagnosis of asthma. Similarly, high rates in Cleveland for children of Latinx or Hispanic ethnicity, and even among white children, higher prevalence. So really common chronic condition of childhood nationally, especially common here in Cleveland and Northeast Ohio. In addition to that kind of substantial just population prevalence, there is substantial statewide heterogeneity, both in terms of asthma burden and in terms of the care children with asthma get. So this is data from an Ohio collaborative across the children's hospitals. Ohio has 6 children's hospitals, 4 are represented here. And what you can see is among children with asthma, seeing disproportionate experience of asthma amongst males, amongst youth identify as Black race, who are publicly insured, and high prevalence of moderate to severe disease. And in particular, things are especially bad here in Cleveland in that more than 80% of our children with asthma are publicly insured. And we have the highest prevalence outside of Dayton of severe asthma. The statewide collaborative found also, in addition to the heterogeneity of the population of children with asthma, marked heterogeneity in terms of inpatient practices, who gets admitted, who ends up in the intensive care unit, what are their discharge criteria, how long do they stay? So major opportunities for improvement across the care continuum, starting in the home, thinking through community settings, what happens in primary care, what happens in emergency care, what happens in patient, and what happens after that acute exacerbation. And part of that heterogeneity may be is definitely driven by practice. Another piece of that may be actually driven about heterogeneity in the disease itself. So what we call childhood asthma is really a collection of airway diseases with varying degrees of inflow limitation. So what this figure is showing on the left-hand side, I'm a pediatrician and a clinician, so I gotta do some clinical pearls here, is a normal healthy airway that's nice and wide open with minimal inflammation and minimal amount of mucus. And then with asthma, have varying degrees of edema or swelling of that lining, increased thickness of and production of mucus lining those airways, both of which, as well as contraction of the airway itself, so narrowed airway overall, all of which contribute to obstructive disease, where you have smaller air pathways, increasing difficulty of getting air to the alveoli for gas exchange. There are different patterns of inflammation, patient to patient, even within the same family, different degrees of sensitivity to cough. And so the degree of airflow obstruction, the burden of symptoms children experience, how much inflammation they have chronically, their susceptibility to exacerbations that could land them in the hospital or progress to severe morbidity or mortality. There's not a linear relationship. It's not even a simple additive relationship. It is complex and synergistic. And part of that is because asthma is multifactorial, and those factors function at multiple levels. So at the individual patient or host level in terms of their, especially related to their genetics and their epigenetics. So what is the intergenerational experience of stress, what methylation is happening in their DNA, which genes in that inflammatory pathway are getting turned on or off. Those are influenced in part by lifestyle. So what kids are eating, how active they are, what is their body habitus, what is the physical sort of load and weight on their chest wall, what are their comorbidities, and all of that's influenced by the environments in which they are growing up. Thinking about prenatal exposures, household exposures, school exposures, daycare, which contribute to what viruses kids get exposed to. We've seen big changes with the pandemic. You know, those kids who were infants in 2020 and 2021, early 21, didn't have a whole lot of exposures to viruses until some of the mask mandates started to lift. And then we saw really big spikes again as those exposures start to increase. What pollens, what allergens, what pollutants, what's coming home on parents' clothes that they're getting exposed to, all of which contribute to both that airway reactivity as well as airway inflammation. And that variability and sort of those factors have defined sort of three major airway eras in asthma care and treatment. So in early days, really focused on airway hyperresponsiveness. So can we take that contracted down airway and open it up? So the earliest medications were beta agonists, which help with short-term or kind of acute responsiveness of the airway. We saw major improvements in quality of life, but along with that, also big spikes in admissions and actually mortality. One of the challenges with especially short-acting beta agonists is you can develop tolerance over time. There's only so many receptors for those medications, and once those receptors are saturated, you can put more and more medication on top. It's not going to make any more difference. And overuse of short-acting beta agonists persists and remains a risk factor for morbidity and mortality for children with asthma. The next phase, partly to do something about that, the next phase of asthma care and treatment was the anti-inflammatory phase. So really focusing on airway inflammation, in particular eosinophilic airway inflammation as the key. So development of inhaled corticosteroids as a mainstay of treatment. So thinking about controller medications, can we decrease that mucus? Can we get the medication to the location where it needs to go in the lungs? And what we found with that was it was much more difficult to implement than the bronchodilators. There's no real-time feedback to a patient. If you're having an acute exacerbation and you can't breathe and you take your inhaler with your beta agonist and all of a sudden your airways open up, you notice that. If you have chronic mucus and you take your corticosteroid inhaler, you might not notice a difference, or you might not notice a difference for days or months, which led to a lot of attention and development of guidelines, both nationally and internationally. Altogether, between 1990 and 2005, so when the main focus was anti-inflammatory treatment, we did see a reduction in mortality and admissions, but a lot of challenges to actual implementation. Not only from a patient education perspective, but also just from a pure implementation perspective. Remembering to take a chronic medication twice a day that you may or may not notice a difference with in real time is really challenging. So in the last 15 to 20 years, the focus has really been on endotype and precision. So really tailoring treatments to the needs of the particular patient, much better understanding of the underlying immunology from the host factors, thinking through and developing treatments that focus more on atopic pathways. So thinking through kids whose asthma is more related to allergies and eczema versus kids whose asthma is related to more non-atopic or non-allergy related underlying pathways, new therapeutics that target different parts of the cell-mediated immunity. And along with that kind of endotype precision medicine, a greater recognition of patient and family-centered care. Whenever I talk about patient and family-centered care, I love to come back to this quote from Ron Epstein from about 10 years ago, which situates patient and family-centered care or precision medicine or tailored medicine or whatever jargon term you want to use, in particular about this final sentence here, that approach to medical care relies on knowing patients as persons in the context of their own social worlds. Or in the immortal words of Valerie Billingham in the disability rights community, nothing about me without me. And you'll mention, I've talked about some general risk factors from a medical perspective, but what has been really missing up to this point is how and when and where and why to integrate individual and family level social data or social context into decision-making, into intervention development and implementation, into treatment efficacy and implementation. And so that's where we're going to go for the rest of the talk. And with that, I'm going to hand off to Marie, who's been with the team from day one.
So when this project was first conceived, it was really, I would say, the broad vision of Dr. Drew Hertz. He was at the time the medical director of the UH Rainbow Pediatric Accountable Care Organization, and he was the original PI on this work. And so his vision was to create this UH geographical health information system in pediatrics that would link multiple medical, behavioral, and social data systems to respond to child health needs, not simply reactively like a health system typically does, but more proactively through the development of multi-sector community action plans and impact measures. He saw integrating data as the key to the migration from traditional volume-based care to more holistic value-based medical care. And key to this vision is the belief that health systems cannot and should not address these various factors affecting patients alone. Collaboration across community sectors to improve health of patients and the community at large is a necessity. Next slide. So in 2016, UH Rainbow, in collaboration with the Case Western Reserve Mandel School of Applied Social Sciences, applied for and received one of 11 academic health, community health peer learning program grants. And these one-year awards were aimed to build community capacity to advance progress of health improvements through expanding shared use of data from diverse sectors. So this opportunity soon grew into a larger national learning collaborative called the All-In Data for Community Health. And its participating members you can see here. You might be familiar, the Build Health Challenge was something that really helped to spur all the work that's being done in Cleveland. Cleveland had one of these grants to work on lead policy. And so some of the lead safe work that has since gone on really started with the Build Health Challenge. This broader collaborative of All In continues today with about 150 different community collaborations across the country, sharing best practices to improve overall health in communities. Next slide. So our project for the Academy Health Community Health Learning Program was called Idea Rich, integrating data evaluating asthma risk in childhood. And so our project goals were to integrate multi-sector data and analyze it in partnership with the community in order to develop a community action plan. And the broader goal beyond just asthma was really to begin here with asthma and then look at asthma as a blueprint for future clinical community health improvement collaborations. And we were specifically focused on this area you see in the picture, the Greater University Circle area that involves a number of different neighborhoods quite close to university hospitals. So we were looking at approximately 15,000 children from the ages of 0 to 18 that both reside in and receive primary care at the time at one of 2 UH Rainbow sites. 95% of these children were covered by Medicaid insurance, and asthma being one of the top chronic diseases and drivers of medical costs overall. Next slide. So these are some of the partners that were a part of that original project, and many of them you'll recognize here. And we really were working together, and the large goal of this project, beyond joining the data, really to look at what next steps can we do, some of what Sarah had just alluded to. Next up, or next slide. So the first year, this was really just a planning grant. So it was a one-year project, and it helped to lay the foundations for the work that we'll be presenting today. So in that year, we convened partners to establish an asthma task force. We outlined the available data and some of the data gaps that might be existing. We identified key questions with partners, and we worked through data use agreements, credentialing, data extraction, and merging plans. We also did extensive data validation with the electronic medical records and claims data. So you see this maze on the side. The start to finish was not completely clear as these bullet points we have here. And it involved a lot of twists and turns of that initial year. So this leads us to our lesson one, which is never underestimate how long it takes to navigate cross-sector regulatory barriers. By the time that we secured the approvals to analyze this data, the project funding was nearing the end. And we had several meetings with community partners where we had talked about our questions, but a lot of the work we were waiting for was to be able to look at this data that we joined and linked together, analyze it, look at anything that could tell us more about what types of interventions might be most effective, and discuss with the community on this. And unfortunately, because it took so long to get our IRB approved and to make sure that the data environment was safe to move the data from the electronic medical records to join them, we got to the point where we had just put all of the data together and merged it, and that project funding ended. And then we go to our lesson 2. So again, something that many researchers here might be very aware of, but matching funders' priorities with partner interests may require creative solutions. And something that we learned the hard way is that funder priorities change. So towards the end of this project, we had a community action plan in place, but not funding to continue. And we had some soft conversations with a funder who was really interested and said, we're not doing a funding cycle now, but in 6 months, come back to us. So we thought, okay, we will pause this for 6 months and then we will pick this back up. Communicated that to our partners and waited. Well, when we came back to the funder, their priorities had shifted and they were really looking for less analysis that we were going to be doing in this next step, and really wanted to have community partners taking the lead. And so they were really focused in a different direction than we wanted this to go for the initial next step of funding. And so we didn't have a funding source at the time. In addition to that, over time, as you also might be familiar with or have experienced, we had a lot of changeover. In fact, Dr. Hertz left university hospitals, and others that were a part of the project moved on. And so I was one of the few people that, as Sarah mentioned, had been a part of this from the beginning. And one of the wonderful things that did happen was that Sarah Ronis took over as the principal investigator, which really allowed us to take all of those approvals and everything that had been in place, and we were allowed to move forward with that. And so then the only question was, okay, how can we make this happen? Next slide. So we looked at this broader vision and knew that we already had these 2 data sets that were joined, and really took the opportunity to reach out to the Clinical Translational Sciences Collaborative and the Community and Collaboration Core to see what might be possible. And so with their generous support, we were able to, we always say, dust off the virtual cobwebs of this project that we felt was so important, and really pick it back up again and begin to work from there. And so Megan's going to share with you some of the results and findings from joining that data.
Thanks, Marie. Yes, hi everyone. I'm going to talk a little bit about what we were able to accomplish with the generous support from the pilot funding. So we were picking back up, restarting, and this slide really kind of shares the primary aims of what we were trying to accomplish with the pilot. So first off, we were just trying to see how feasible was it to link these medical records to our child system. And the child system, for those of you who are not aware, is housed securely at the Poverty Center and is an integrated data system with over 35 different providers and data partners. And it starts with birth cohorts back to 1989, and it has a lot of really rich social information. And so we were trying to see how feasible it was to link that data system to the medical records that were provided. And then the second aim was to take that linkage and to provide descriptive findings among those children that we were able to match, really focusing on their demographic attributes, school variables, including school absenteeism, and then those modifiable health-related social and environmental factors that could potentially provide us with clues as to points of intervention. And then finally, this was, a pretty descriptive analysis that honestly raised a lot of questions, and it answered some, but raised more. So we came out of it with a lot of research questions that could potentially follow from this, and thinking through what's the strategy in terms of what might be a promising way to fund some of this work. You can go to the next slide. Thanks, Sarah. So I'll quickly walk through the data sources that we used, our sample, and a few of the findings. So we started with that pediatric patient record data set that had been pulled as part of the original effort. And so that was children aged 0 to 18 who had at least one outpatient pediatric encounter between 2013 and 2017 at either RPP, so Rainbow Pediatric Practice, or Otis Moss. So note here, we only had the outpatient records. That was something that in the end we decided was a limitation, because having inpatient asthma records would be helpful for future. But this was great. It had over 20,000 children in it, and the data elements included their demographics, important identifiers that were used for matching, dates of encounters, test results, diagnoses, flu vaccine information, prescriptions, and then if they had an asthma diagnosis, for some, we had an asthma action plan. The other data system that I just talked about is the child system. It includes children born in Cuyahoga County from 1989 to the present, and others who may not have been born here, but may have received services or touched one of the other systems for whom we have data sharing agreements with. And some of the most pertinent records that we used for this particular analysis were juvenile delinquency filings, educational records, including kindergarten readiness, chronic absence in school, repeating grades, birth and family characteristics, largely drawn from birth certificate records, public assistance receipt, lead testing, so both whether or not children were screened for lead poisoning, and then if they had an elevated blood lead level at any time prior to the age of 6, any homelessness or use of emergency shelter, and child welfare involvement. Go to the next slide. So the first step was to look at that EMR data and identify, of all the children who received outpatient visits in that time period from those two providers, which of them had an asthma diagnosis. So that could help us to identify both an asthma population and then a pediatric population of children seen without an asthma diagnosis as a comparison. So we used the ICD-9 and 10 codes and to identify asthma diagnoses. And then we did some subsequent analysis within that group to see how much we could know about the severity of the asthma and the extent to which that asthma was under control or not among the asthma group. And then, like I mentioned before, we rely heavily on these key identifiers across data systems to link data. So we use probabilistic matching to link the EMR records to the child system, and the key identifiers that we use to ensure that it's a correct match is first and last name, date of birth, sex, race, legal guardian's name, and address. If we have all of those things, it's really helpful to us to ensure that we have the same child identified in both data systems. And then finally, I mentioned our group of children with asthma. We created a comparison group of those children from the EMR who did not have an asthma diagnosis. And then for the purposes of just setting context, we identified a third group, which is like another comparison group. It's children of the same age, residing mostly on the east side of Cleveland, because you'll see in a future slide that's where the majority of these children lived, who lived there but were not present in the EMR. So these are kids who lived on the east side of Cleveland who did not go to one of these two pediatric clinics. And that the sample we pulled there was over 8,000 children. And that will just serve as kind of just an anchor of a contextual variable comparison group. Next slide. So now we'll talk a little bit about the findings. The first aim, right, was to see, was it feasible to link this data? And the answer was resoundingly yes. Of the, I think it was 21,733 children in the EMR records, we linked 20,382 of them to the child system. So that's a 93.8% match, really, really high match. And we felt really confident that, we were capturing the majority of the children in our data system. Of the pediatric records, we found that 18% of that group had an asthma diagnosis. And of those, they were more often male, Black, history of prematurity and or low birth weight. And as I mentioned previously, the majority of those children resided on the east side of the city. The map on this slide, yellows and greens represent higher numbers. So you'll see that we're seeing a lot more children on the east side. Next slide. So now I'm going to walk through some of the findings through these tables, and just quickly to kind of run through what we're looking at. The columns represent those 3 samples that I mentioned. So the leftmost column are the 3,241 children that we identified with an asthma diagnosis. Next to that are the remaining children in that pediatric sample who did not have an asthma diagnosis. And then third column is that contextual east side of Cleveland, same age group, same time period, but weren't in the medical records. We're looking here at percentages. So the share of children who had each of these characteristics. So in this slide, we're looking at birth characteristics and lead testing prior to their first appointment, or when we're seeing them in those medical records. We did chi-square tests to look for statistically significant differences across groups, and we were comparing to the UH asthma population across both. So it's a little bit hard to see, but when a number is bolded, that means that it was statistically significant. The difference between that group and the asthma group was statistically significant. So I want to call your attention to just a couple of things in this table. We're seeing low birth weight and prematurity. Around 20% of the children who had an asthma diagnosis were either low birth weight or premature or both, compared to only 14–15% in our comparison samples. And then similarly, if you look at the lead testing, we see that the rates of a confirmed elevated blood lead level are not statistically different across groups, but really high by anyone's imagination and worth studying on its own. However, when we're looking at statistically significant differences, we're finding a difference here on the variable of whether or not they received a test prior to the age of 6. And we're seeing that among the asthma population, the children actually, more of them were actually tested than in the comparison groups. And what that means, this is a future research question, but perhaps it has to do with the fact that they have asthma, so perhaps they're going to the doctor more frequently. And the more frequently you go to the doctor, perhaps the likelihood of you getting a lead screening goes up. Possible, perhaps they're more likely to be on Medicaid. There's more rigidity around Medicaid and lead testing. These are just some hypotheses, but interesting to point out the differences there. Next slide. Okay, so this table structured exactly the same, except now we're looking at systems involvement and public assistance usage across these same 3 samples. You'll see there's a lot of bold going on in the 2 rightmost columns, and that's really indicating that a trend that's pretty consistent among the asthma population. Just more connection to these systems than we're seeing in the comparison samples, pretty much across the board with just a couple of exceptions. A higher share of children with asthma had a substantiated incident and any contact with DCFS in general. More likely to be, or just a higher share are present in all of these public assistance programs, be it SNAP, TANF, daycare subsidies, or Medicaid. We're seeing the asthma population to be more represented in those systems. Next slide. And finally, we linked the same group to school records. And again, I'll just point out where we're seeing statistically significant differences across group, and it's really coming out with the share who had repeated a grade at some point in time, and then those with chronic absence. And again, I don't think the pattern is necessarily that surprising, but children with an asthma diagnosis, a higher share of them had either repeated a grade or had missed more than 10% of school days in a school year. So I think, like I said before, this answers some questions, but raises a ton more of potential research questions. As these are just descriptive findings and warrant a lot more rigor and investigation. And really, like, the connection to services and systems could be an indicator of risk and the intersectionality of risk. It can also be an indicator of connection to support. And so it's kind of a gray area that needs to be teased out more. However, I think some of this linkage also really sheds light on potential areas for intervention and potential systems that touch these children that could be integrated with the health community to try to really tackle this from a more holistic perspective. Next slide. I think we're going to turn it back over to Sarah. Thank you.
So I think the third message that we want to share is, and I think especially many of you who I see on the line who I know do community engaged work, is just the incredible importance of communicating early and often, and celebrating even small wins or kind of steps along the path. I think one of the lessons learned that we had, often when you're presenting, you want to sort of share the polished final version. And I think this experience with this project has allowed us to have some opportunities for some reflection and humility, particularly about the roles when you're working with large institutions and some of those regulatory policy barriers that can sometimes slow that communication, and finding other ways to stay engaged with the broader team. Which sort of leaves us, okay, so where are we going now? As Megan mentioned, the work that was really generously funded by the CTSC Community and Collaboration Corps allowed us to dust off those cobwebs, to start to explore the data and to open up a number of pathways or potential directions we could go. So in the interest of just full transparency, funding remains a bit of a challenge with this project. And so we've pursued a couple of different paths, some from more of the academic institutional side, following opportunities, funding opportunities from NIH, from AHRQ, just keep this work moving forward. We were lucky enough, based on this pilot data, to be invited to contribute a demonstration project proposal as part of the CTSC's Module E submission. So we will see what comes of that, and are working on a resubmission to the Agency for Healthcare Research and Quality for the fall, focusing on starting to untangle some of those really, I think, interesting, provocative questions raised around the connections with community benefits and relevant benefit programs, focusing in that situation on the preschoolers in the cohort. I use this photo because we're moving, but we've got some stuff that kind of keeps cropping up. I wanted to throw it back to Marie and Megan for some other sort of final thoughts, reflections before we open up to the group for conversation.
I have a 6-year-old diagnosed with asthma in my space, so I think I will leave it there, but I'll try to pick up in a little bit. But Megan, do you have anything else?
Sure. I just want to thank Sarah and Marie both. We really, at the Poverty Center, really enjoyed this collaboration and love opportunities to use our child system to link to new sources to provide insights in new ways. So we would love to be able to continue these kinds of partnerships with both of you and your center and anyone else from the community who.
Thanks, Megan. Yeah, so that's the end of our kind of formal comments for the morning. Looking at the chat to make sure I'm not missing any kind of questions or comments there. I see a question from Jess Song. The asthma group in Eastside were not significantly different in school sum record. Looking at those percentages, I'm going to push that one back to Megan.
Sorry, can you repeat it again? I didn't see it in the chat.
I think the question was whether or not identification in school records was statistically different between the Eastside comparison group and the UH asthma group, given the difference in percentages there.
Sorry, which indicator was it? Sorry,
Some school record.
Some school record. Yeah, no, it wasn't. And I'm not sure why. You can look back at that one to be sure, because those numbers do look different from one another. So let me take a look and I can get back to you on that one. But really what that means is we only have agreements with CMSD and the inner ring, I think 10 of the inner ring suburbs. So it's really, and it's only the public schools. So it could be interesting to look a little bit more at that. So why are we seeing certain groups, more of them in those schools versus other schools?
All right, everybody, is it more questions from the group? If none, I can ask one. So can you guys talk a little bit more about the geographic relationships? Like, so I would imagine this data would be very useful and also like identifying spaces, right? So where are these connected variables actually the most predominant? And then is there a way in which to do sort of a geographic targeted space around asthma?
That's a brilliant question, Dr. Borowski, and I think spot on with where we would love to take this next. Based on the link, I'll let Megan correct me if I'm misstating this, based on our ability to link, we do know where kids live and where they're showing up in which schools they are showing up in records there, which I think is another sort of flip side. So I mentioned sort of from the academic medical center side, like what is our pathway for keeping projects going? We secure grants. And the way to secure longer term grants that allow you to really do that sort of longer term community engaged work tends to be more on the federal level, where you can plan on a 3, 4, 5 year time frame as opposed to a 6 month or 1 year window. So that's sort of not that for securing federal funding is low hanging fruit, but you guys follow me. That's sort of the low hanging fruit piece. On the flip side, I think the other potential for this and why we're so excited to get to share this pilot work with the broader community is there's a ton of richness with this connected data set that I could see being leveraged as intended from the origins of this project to help guide an asthma task force, community engaged, other community leaders or community stakeholders, and saying, okay, let's identify the schools where we have the highest rates of absenteeism for children with asthma, and can we develop some tailored interventions that focus on needs of kids in those schools, whether it's school-based or neighborhood-based. Let's identify those residential tracts where we're seeing highest rates of asthma and or engagement with community services. And is that where we start targeting outreach in a very bi-directional fashion? From the primary care practice, if I know which school my patient is in, even if they haven't been diagnosed with asthma, maybe that's going to be a cue for me to think more proactively about preventive interventions in the home or coaching around what they can do for school. So I think there's a ton of way to do this. And I think the richness and the geographic linkages here are especially potentially powerful.
Particularly because it does seem like it would be helpful to understand, and I know you had Environmental Health Watch and others involved, like, what are the risk factors that are associated to the home versus the neighborhood air or quality and things like that to kind of hone in and do those vary across these geographic spaces, and so that would be, being able to disentangle some of those and then build interventions around it. And having this data set as the backup, I would think it would be very powerful for a grant, right? And for a study to really try to understand, because you'd have the data in which to really tease it apart and then target it.
Absolutely. Yeah, I think the multi-level nature of this data and the fact that it's individually identifiable. These, I mean, on Megan's team side, we don't see that level of data when it gets output. But again, the fact that you can actually say, you know, this is not population averages or neighborhood averages or kind of, but actually these are living, breathing human being children that this is tied to.
Yeah, awesome.
Yeah.
Lots of potential.
Tons. I see a question from Gabriella in the chat. Curious, and if so, where you see policy opportunities for improving access, treatment, et cetera, based on what you're learning. Great question, Gabriella. One of the pieces that Megan talked through that I find particularly, again, I think this is more question than answer at this stage, was this actually honestly unexpected finding, because I would have hypothesized the other direction, that we are seeing some signal that the children who were diagnosed with asthma seem to actually be better connected to care, at least from some of the things we're seeing in the administrative data. And we didn't show these analyses, but we saw that even kind of in a dose response rate in terms of severity. So the more severe the child's asthma was, the more connected they were with their preventive care, the more likely they were to be connected with social services. And so before seeing that data, I would have expected that relationship to go the other direction, that you'd have more competing priorities and therefore not be getting in. So for me, it raises all kinds of questions about the kids on the East Side and the kids without asthma in terms of who are we missing? And maybe even some opportunities to intervene on that side in terms of being thoughtful and creative about, to Dr. Borowski's point, is there geographic signal in terms of neighborhoods or communities where kids are less connected and allowed in that to drive some tailored outreach. I don't know, I've been talking a lot. Megan, Marie, you guys have stuff to add?
You're doing great, Sarah. I don't think I'd add anything. I think, I mean, you're pointing out all the things that I would have noted from what we saw in the administrative data.
Mm-hmm.
Yeah, I think that the other piece being that our sample is limited to the children from these two specific practices that do focus on the East Side of Cleveland. So, you know, so I think that for additional information, it would be good to be able to look more broadly. I think that the other focus this was one piece in time of a certain period of time of data, and we didn't have additional data that was going forward. So being able to, Megan mentioned, look at the inpatient and outpatient records, joining the claims data, and being able to move forward to have a prospective data set would be extremely helpful in being able to focus more on sort of what kind of interventions could we do, what kind of policies are having impact over time. So that's another limitation that we still are working around and figuring out how do we move forward. Because I think ultimately we would want to expand this from beyond just this 4-year data set that we have to be able to move forward.
Yeah, can I ask one more thing about this? You know, it strikes me though that, well, hang on, I just realized we have a couple things in the chat. Sarah, you reading these two just before I ask my question?
Yeah, so Jodell agree that there's multiple variables that related to geography. Yeah, we 100% agree. Yeah. And then Melissa Lanier, yeah, we'd love to chat about, I think there's, to Maria's point about, and I should just reemphasize the comparisons we're looking at are patients who got care in the UH system. We live in a region with 4 major systems that serve children between University Hospitals, Metro, Cleveland Clinic, and Akron Children's. And while over the last 10 years, most of the private community practices have consolidated into those 4 systems, and kids don't stay solely in a single system. We're blind to the care that they're getting outside of our institutional boundaries, which is where the claims data, which we just have to get it physically into the space, is sort of the next big leap, because then at least for the Medicaid insured kids, regardless of which system they're getting care in, we'll be able to have some visibility on those pieces.
So the comment I was going to make, Sarah, that I think is fascinating is that you were a bit surprised by the relationship between sort of the engagement in other social services and that. But in some ways, I think that's a bit reassuring, is that the kids that are quite at risk are actually being touched. They are, they are being connected in these other spaces. They just happen to be, we don't, without knowing exactly what's driving, right, the asthma itself, if these are environmental or home, or is it smoking? Is it, there's all kinds, along with other kinds of health conditions. But because I noticed they're also more likely to be low birth weight, right? There's other kinds of risks. In some ways, it's reassuring that they aren't less likely to be connected, because that would be really troublesome. But the fact that they are connected is kind of a nice finding that there's connectivity. That means there's real potential, hopefully, of interagency relationships, right? And if the healthcare systems, if they connected with each other first and then connected with everybody else, you could see that the network is already sort of there.
Mm-hmm. Absolutely.
And I think that's worth a paper in itself, because I do think that most of us would have had the assumption you said initially, which was the assumption that the kids were less connected. I don't know if Gabrielle, if you were one that suggested, like, would you have thought that, or is this an interesting finding that they are in fact connected?
I agree with Sarah. I think this is somewhat surprising
Okay.
finding. And I'm curious, I know we're almost out of time, but another question I had, if I might ask real quick, is on the education data. Did you happen to look at experiences of discipline? I know you looked at absenteeism, but I'm curious if this population, you saw any descriptive connection with discipline data.
Well, unfortunately, we don't receive the discipline data, so we weren't able to look at that one, but I do think that would be an interesting one to look at. And just to the point around systems involvement, I think you're right. They clearly are being touched by these systems, but I think what needs to be disentangled is that because they're higher risk, or is it because they're more connected, or it's some combination of the two, but it definitely warrants further exploration for sure.
Mm-hmm. Fascinating. Okay, well, we are at the hour. I just actually asked the question whether we go to 1 or 1:15. I cannot remember. So, what else saying? So, any other questions or comments? Yes, I think we're echoing those. Great presentation. All right. We can go to 1:15. Okay, so if others, thank you, Erica. So any other questions? Just very anxious to see where you can go with this next. I do think it warrants a really big grant with putting a lot of people in place. I think that's what it would take, because you have to bring, it seems to me like the different healthcare systems have to come together to attack this also. Right. So how do you do that first? Whether it's through Better Health Partnership or something like that, where, these things could all come together, and then you use your other pieces to actually make some plans for interventions.
Absolutely. And I think the other advantage to finding a longer term source of funding to keep the work going is I think then that allows, provides a little bit of infrastructure for meaningful ongoing community partner engagement in what are the questions we should be asking, what are the pathways for intervention, because I think that in this hour we've talked, mentioned probably 6 or 7 different hypotheses that could each be their own project. And so I think figuring out the right time to reactivate the network and or rebuild the network. And I guess I'll put this as just a general kind of call that if anyone is interested in collaborating as this evolves going forward, please let me, Marie, or Megan know, because as we know, the work doesn't fit nicely into grant periods.
Yeah.
So that's where I want to, that's my vision for this.
We also know that everybody loves data, but nobody really wants to pay for its sustainability. So that's another unfortunate problem with this kind of work.
Absolutely.
Erica, do you have any last words?
No, this was fantastic.
Yeah,
Thank you
it
so
was.
much for this presentation. I am just really excited about the conversation and direction that you all are going. And thank you for presenting today. Thank you
Yeah,
for,
thank you.
thank you, Elaine, and to the CTSC Community and Collaboration Corps for co-hosting and for bringing this important work to the PRC seminar. This is fantastic, and I'm excited to see the connections in the chat as per usual. Hopefully, Melissa, you have the contact information, or you know how to reach these folks, or you all can coordinate that in the chat. But for everyone else, just a reminder, we will be posting this up to our website. So you will usually within 24 to 48 hours. So if you'd like to also share this with other colleagues who weren't able to make it, you can share that link and share this work with them. Thank you so much to everyone, and enjoy the rest of your day.
Everybody.
Oh, and before we go, I always just like to say, please, if you can turn on your cameras, and let's just give our speakers a round of applause and
Yeah.
enjoy seeing each other together.
Thank you all. It was awesome. Lots of hard work.
Absolutely. All right. Thank you all.
Bye, everybody.
Bye.
Bye.